conference that we are going to talk about the allergy management in our patients. So let us move into the topic without further any delay. I work as a consultant pulmonologist at Vela Hospital. I've been working there for the last 2 years. So I'm sure quite a lot of conferences, CMEs, what we talk about the pharmacological therapy and the other routine aspects as far as asthma and COPD is concerned, the inhalation therapies. So switching over to slightly a different topic. In fact, this is something which is emerging over the years, and several research has been going on based on probiotics, microbiome theory, lung health, lung gut axis and all. So I think Forts has taken up the initiative to launch such a molecule so that it can also help the patient in multiple ways apart from clearing the allergic symptoms as well as reducing their IgE counts. So let's go into the topic. So you all know the allergy is a perennial problem in our country. In fact, most of our patients, I am sure you would agree, those who come into the OP, more than 50% would be suffering from any type of allergic disorders, be it allergic rhinitis, they may be having conjunctivitis, some may have atopy, dermatitis, and of course bronchial asthma. So there are several allergens which we know. Some may be a food allergens, some may be due to your aero allergens, and there may be even the house dust mite, which is commonly implicating. So to identifying the allergen factor and treating it efficiency is paramount in these patients. Mind you, allergy is not curable. It's an hypersensitive reaction in genetically susceptible individuals. It is only controllable. But having said that, if you can avoid the triggering factor, which we fail to do in most of our cases, or we may not know the triggering factor, so that is the step one. So the symptoms may not be coming. Second is to understand the impact of allergy in our lives. So for example, if you take bronchial asthma, so we need to look at the patient's symptom on one aspect, on the other side the lung function, which is very much important. Even in asthma, what you can see is that there may be symptom free periods where the lung function may be perfectly normal. So in those patients we usually advocate peak expiratory flow rate assessment, and of course with latest equipments we have our impulse oscillometry and FeNo, so that we can guide precision treatment in these patients. And once you have diagnosed the disease and gone into the classification of mild, moderate, severe, or whether it is intermittent or persistent, seasonal or perennial, the next part would be in the management of such patients. So we have a multiple range of molecules and therapy in this, and adding to the addendum of that is one such we are going to discuss about the probiotics. Next slide. So this was data which we are able to look up actually. Somewhere 40-50 years back, what we found was the prevalence of allergic rhinitis and asthma was less than 10% in our country. However, the recent studies and trials, what they have shown is this burden has increased proportionally. Mind you, whatever we are seeing now in our practice is only the tip of the iceberg. Quite a lot of patients are self-medicating, they land up with the wrong prescription, they get wrongly diagnosed, and even in rural areas, what we see is these patients are getting diagnosed as pulmonary tuberculosis, having an empirical therapy of anti-tubercular therapy. So what I mean to stress in this slide is the burden of allergy has exponentially increased, and most importantly some triggering factors. The air quality index is actually getting worse by the day, and especially we living in a metropolitan city. So we come across quite a number of patients who suffer due to allergic disorders because of poor air quality index. So in cut short, what I say is what was 10% has increased to nearly 20 to 30%, and this volume will just keep on increasing if we don't step in and identify these patients. So as I said, we'll just focus upon allergic rhinitis, then we'll talk about the molecule per se. So we all know the allergic rhinitis can be divided into all these things. We have the area guidelines, ARIA, where the allergic rhinitis and its impact on asthma is studied basically. So first we need to identify whether it is a seasonal one or a perennial one. Perennial is something the patient is having symptoms for almost 365 days a year. Then we need to look for the severity category, whether it's mild, moderate or severe, and that also we can subclassify into mild persistent, moderate persistent and intermittent. So based on this symptomatology, I think it will help in guiding the treatment decisions of the patient. So whenever we say about allergy, the most important thing that comes up in our mind is the Th1, Th2 imbalance. In fact, the Th2 levels are significantly increased in allergy patients, leading to an increase in inflammation, mast cell degranulation, the increase in blood IgE levels. Because of this imbalance, the patient is having most of the symptoms. Although this is not mandatory or seen in all patients, some may have a neutrophilic inflammation, there may be a atopic, only eosinophilic inflammation. So this is an important characteristic, and apart from this, we also have other mechanisms playing a role. But today, for the molecule and for the part of the discussion, we'll be talking about the Th2 imbalance and increase in IgE levels, which is actually contributing to majority of your symptoms. Yeah, so we all know what Ig is. I don't want to go deep into that. So we have multiple immunoglobulins, your IgA, M, E. So E is responsible for your allergic triggers, and that is what we'll be discussing subsequently. So this is again a pictorial representation. I'm not able to pinpoint and show you. So in a normal patient who's not allergic, when they are presented with any antigen, so there are two sets of patients. One, you have a normal patient or a normal person, in fact, another who has an allergic response. So what you can see, the degree of response changes in both of these patients. On the left side, you can see the physiological state. When they are exposed to an allergen, the APCs come into the play and the allergen is cleared from the body by the IgG immunoglobulin, which is the police force of the body. However, in a patient who is sensitized to allergens, and when they have a re-exposure, apart from IgG, you can see multiple inflammatory mediators, mast cell degranulation, release of histamine, interleukin, cytokines is happening in these patients, and the IgE molecule is also released. This also leads to an eosinophilic inflammation in our body. So this is the major difference. Quite a lot of time patients come to the OP and ask, like, there are 10 persons in a room, only few are having an allergic response, why not the others? So an important aspect is the sensitization and the re-exposure that has been happening in these patients. Mind you, most of the allergic events are all familial. They have a strong family history. Sometimes one generation may be skipped, their grandparents may be having this. So these are some things which we need to look into it when we are considering any patients with allergy. Perfect. So we all know the treatment, how we can give. So there are supportive medications, then you have anti-inflammatory therapy. So any allergic response, you need an inhaled corticosteroid. So that is more important, either in the form of a nasal spray or you can have in the form of an inhaler. Sometimes the patients may need also oral steroid for a short duration of time. But what we have seen is there's an indiscriminate use of steroids across over the counter, and patients have been taking it for prolonged periods at suboptimal doses, heavy toxic doses. And what we see is a small subset of patients, probably whom we will label as severe asthma or difficult to treat asthma. What you can say is these patients do not respond even after optimizing your medical management in terms of your inhaled corticosteroids and even a short burst of OCS. The other aspect, what do we do with these patients? There are three options actually. One, with the recent advances, what we know is the biological therapy, where your omalizumab, benrali and mepolizumab have come into place. So adequate patient screening, identifying the right subset of patients, FeNo endotyping is very much essential in these patients. And omalizumab also has certain limitations based on the body weight and the IgE levels. If the IgE level is significantly higher, roughly more than 1500, the dose of omalizumab is not well established, and also many obese patients where their body weight is more than 90 kgs. So there are some fallacies when we deal with Ig mediated inflammation. Similarly, stringent workup and to identify other modified risk factors is needed in these patients. The second thing which gained some importance in the last decade and extensively used in US, UK and Europe is the allergen immunotherapy. There are two ways. One, you have a sublingual immunotherapy and the subcutaneous immunotherapy. Mind you, this is actually an allergen tolerance induction. So the allergen is given at a suboptimal dose. But one limitation here is the patient must have a good FE1. If the FE1 is less than 70%, this allergen itself can lead to an acute exacerbation or attack. That is more important. The second thing is long follow-up period is required, 3 to 5 years. That may not be practically feasible in a country like us. And also, the evidences are pointing more towards a subcutaneous immunotherapy rather than a sublingual immunotherapy. So in addition to this, there is a middle path or middle way, what we can say is how, when we talk about the probiotics, how it can impact at the origin level, maybe we can prevent these problems. So moving on to the unmet needs, so we need to balance the imbalance, that is the Th22 balance, and also go into the root cause of the allergy, not from treating other things. So this is where microbiome steps in, and what you can see is nearly in the last 10-15 years, there have been several studies and research which has been going on in these patients. What you can see is, according to this, simple aspect, what is the probiotics and the probiome has a positive influence on the host, and that is where we'll be looking into subsequent slides. So one way you say probiotics, what is in your mind? There's only one word that's going in. Let's move forward. So whenever we say probiotics, we all think of an acute gastroenteritis and the patient is having some loose stools. But probiotics are actually much beyond that. Of course, it helps in your AGE, but we need to look at other aspects also. So several research published in Nature, Springle and other eminent journals, what they have found is, so it enhances the immunity, it decreases in allergy, it also helps in controlling diabetes, hyperlipidemia, helps in osteoporosis, and to some extent in cancer level. Also the research is still going on, and depression and anxiety have been found in several studies. So what we see is probiotics do 4 important things which I would like to focus on. One, it helps in protection, modulating the immune response, and the second is it enhances the absorption of essential vitamins and minerals. The third thing which we are more concerned about is the intestinal motility and maintaining a proper gut health. And finally, moving on to fourth thing, it helps in the production and increasing the level of short chain fatty acid, butylate, vitamin K2, and finally it modulates the allergic response that is happening in our patients. So this is the most important slide which I would feel for the basis of the launch of this molecule or the requisite of this molecule is the gut-lung axis. So several studies have shown that the microbiome which is in the respiratory tract is more or less similar to that in the gut. And also we are talking about the short chain fatty acids here. They have an anti-inflammatory as well as an immunomodulatory property. So because of this, what they have found is they have found to improve the immunity of the patients, increase in Th1 and Th17 levels. The cytokine expression has been modified in these patients, and there's a decrease in Th2 expression and allergic inflammation which is happening in these subset of patients. So we'll see what is the key cell that regulates this Th1, Th2 balance. Going a little bit into immunology and microbiology is your dendritic cell. I'm sure all must be knowing about this. So in fact, for identifying the dendritic cell is the most important cell which helps in adaptive immune response and Th2 activation. Dr. Ralph Steelman was awarded the Nobel Prize in Medicine in 2011. So what you can see is when we give the probiotics, they activate the dendritic cell, so it restores the Th1, Th2 balance, and there's a decrease in IgE level from a immunological perspective. But when we see from a patient perspective, the IgE is responsible for quite a number of our symptoms. So there's an improvement in the patient symptom, quality of life, lung function, and other aspects. So just going into the intestine, when we have a macroscopic enlargement, when we need to give probiotics, and that to a specific probiotics, that is what I would say, because there are quite a number of probiotics which are available in the market. So we'll talk about the specific probiotics, and when we give that, so there's actually molecule called the Peyer's patches which is responsible for the absorption in the intestine. Let's move forward. So these probiotics enter through the Peyer's patches, and they are the immune sensors of the intestine. I'm sure you can see a histopathological image of the Peyer's patches and the villus in this slide. So what does it do? It activates the dendritic cell. The dendritic cell in turn regulates the Th1, Th2 balance, and therefore leading to a decrease in the IgE levels. So this is what they have said, and therefore the allergic symptoms of the patient is also reduced significantly. So when we talk about probiotics, what are the specific probiotics? Does all probiotics are the same? So even in curd, fermented milk, and quite a lot of natural products also we have probiotics. We are going to talk about 2 specific probiotics, which of Allergy is made of. Let us look into it. So the simple answer is all probiotics are not the same. The strain, species, and quantity and quality is very much important. So these are the multiple sets of probiotics here, and we can see on the clock. So I don't want to go into detail with each and every probiotic. So we'll be focusing about 2 probiotics which is in Allergy. One is your Lactobacillus paracasei and the Lactobacillus fermentum. So these are the most studied allergic probiotics, and several research has been going on for the last 25 years in these probiotics, and after which this molecule was launched. So this is what they claim to say, the only documented anti-allergic probiotic as of now, what we can say. So there are several studies, but quite a few are local or Indian studies which have been done across the center by ENT doctors as well as physicians alike. So what they wanted to see is what is the safety and efficacy of this molecule in those who are having a perennial allergic rhinitis. So you can see it was a study with a relatively less number of patients, roughly 35 patients, a 3-month duration study. So what they found in these patients is, one is there's a reduction in the symptom. So that is what the patient is asking most of the time. The second thing, when you see the patients as a decrease in IgE level. The third thing, when you assess objectively with a questionnaire like a St. George's Respiratory Questionnaire, the Rhino Conjunctivitis Quality of Life Questionnaire, so there's a very much improvement, not only subjectively but also objectively. The severity and frequency of symptoms are also subsequently reduced. What you can see in this study is a 40% reduction in severity and a 64% reduction in the IgE level. So someone who's having an IgE of, for example, 3000, when they have been given this, so imagine it is roughly 64% leads to less than 1500 level. That has huge clinical implications for the patient and the further management also. It's not only the transient reduction in IgE we are talking about. The second thing, if the patient is continuing to having a persistently high IgE level, the patient may be subjected to other alternative therapy which may not be cost effective for the patient. So as here we have some alternative therapy where, in a way, using the probiotics and the gut microbiome, where we can actually decrease the IgE level in these set of patients. There's one more study which was done in Karnataka. So this was an observation study. Here also the patients with allergic rhinitis were included, roughly around 50 patients. They were studied for around 6 weeks. So what they said, in these patients also there's an improvement in the visual analog scale score. The IgE levels were significantly reduced and the symptoms were better. So those who are on your Montelukast, Leocetrizine, your nasal sprays, when given as an add-on therapy, in this study what they found was the reduction in IgE level was roughly around 53%. So there's one more study running again. This was again run in Karnataka. So what they found is an add-on probiotic with an antihistaminic helpful. So this is a large study where roughly 100 patients were there, and it was a double-blinded RCT. The patients were studied for a period of 6 weeks. So what they found is they have a synergistic effect in reducing the symptoms as well as decreasing the IgE levels. So with all the studies, what we have seen is one thing which is very much common, that is the decrease in IgE level is significant. The second important aspect is the symptom frequency and the quality of life is much better in these patients. The only thing what we would see is these are all the studies are based on a very short-term basis. So long-term follow-up of these patients are required. I'm sure multiple studies are going on across the country as well as across the globe, so where we can get better data than this. So this is what I thought the international evidence. This is actually most of the evidences have been from across the globe. Actually, some studies have been done in Italy, one neighboring country, Pakistan, then we will at China, Germany, and Nigeria. So all what studies have been found is that most of the patients have an concurrence the studies with our Indian study, and they found the same effects. So not only in allergic rhinitis, even in asthma, this plays an important role. The Th1, Th2 imbalance is restored. There's a synergistic effect. So this point I would like to stress is, if you give Allergy, do we need to give other anti-inflammatory therapy is what we frequently ask. So this can be given as an add-on therapy which is totally safe and has good efficacy, and in these patients they actually play a synergistic role. So in a simple way to put is, it treats the root cause of allergy. Just like imagine any patient for a tertiary prophylaxis, you give aspirin. So whenever a patient is having a hyperlipidemia, or they're having one cardiovascular accident, or as a CV or CAD, we put the patient on an aspirin for a long time so that the patient does not have repeated episodes. Similarly, what I would suggest in these patients is you can actually try this capsule in those subset of patients. Of course, we don't have to take for a long time like aspirin. What the current recommendation advises 1 capsule per day, at least for a period of 12 weeks. So based on that, then you can reassess the patient always and take a decision. So there are 3, although data has not been provided to me by Forts, but I'm sure they are a very safe molecule. They have been proven across globally as well as in Indian patients, and especially the US patent is there in these patients, and this has been trusted across India and also other countries, and this molecule is slowly gaining traction in our patients. So in a simple way, if I may, in a nutshell, if I may conclude that allergy is a perennial problem. So we have a lot of patients presenting with different forms of allergy. So what we are treating is only the tip of the iceberg. We need to look at the root cause and manage in these patients. Majority of our patients are having an IgE elevated allergy, what we call as the atopic. There may be some patients who are a non-atopic, non-eosinophilic type, so where a different set of treatment is required. Some may have a predominantly eosinophilic inflammation. Even in these subset of patients, this molecule has found to work better. And the other thing what I would like to stress here is you don't have to replace this with any existing therapy. You can always consider it as an add-on molecule so that it has a synergistic effect. And especially for the layman or the poor patient who is not affordable into going into biologicals or the alternative therapy, this can be considered as a therapeutic option which is very promising. And with evidence or the plethora of data that is coming in, I'm sure we will be seeing quite a lot of patients who are getting benefited with this molecule actually. Yeah. Thank you. So sorry for putting this slide. I just wanted to just tell this is I've been working here for the last 2 years, and there are some of the things which we have been able to do in our institute. Actually, the center picture I'm sure sir recognizes Dr. Mohan. So we did a lung transplant last year, and the patient is doing well right now. She's a Gujarati patient, and recently, of course, we have seen a rise in fungal infections, which we wanted to highlight. And this patient was actually referred to us by Dr. Praveen actually. So there was a patient with foreign body aspiration, which we were able to remove, and there were some interesting debulking cases. So I take this platform as an opportunity to tell us that we also cater to the patients of interventional pulmonology as well as clinical and infectious diseases. So if you have any patients, just kindly let us know. Thank you.